You could come in and have a seat. We would love to get started this evening. We want to welcome you, those that are from around the corner and those that have come from other counties, from other cities, from out of state. We appreciate you being here today. We appreciate the passion in which you support this work and this event. I would like to ask if there's any elected officials, if you would please stand so that we can honor you. Wave your hand. Do something. Commissioner Carswell, you know I can't go without giving you a shout out, and we thank you so much for the part that you had in putting this together this evening and the support that you continually give the citizens here in Burke County, especially on this topic. Thank you all for taking time out of your evening, out of your week, to be here, to talk about this issue, the issue of the overdose crisis, the opioid crisis, substance use disorder, and what we are doing as a community, as individuals, as organizations, and as a nation to address this. I'm delighted to share some uplifting news with you this evening regarding our ongoing efforts to combat the opioid misuse within our community here in Burke County. And I have a lot of stuff written, and I'm going to try not to look at it, but I do have some numbers that I would like to share. I guess I should probably tell you who I am. I am Michelle Mathis, and I am the Executive Director and Co-founder of Olive Branch Ministry, and we provide harm reduction services here in Burke County, and we have done so since 2012. I would like to share with you about the fact that in this county alone, from January until April, compared to the same time period last year, we've had a 51% reduction in overdose emergency room visits for overdose. %51%. That is amazing. At times, Burke County has been in the top 10 in the number of overdoses in the state, and we are no longer there. And it has to do with community partnerships, many of whom you've seen on the advertisements for this event tonight, and so many other partners that have gone unmentioned this evening. But we're all working together to address this issue, to save lives and to make Burke County a healthier and safer place to live. I want to talk to you about the expansion of the Olive Branch Medical Hub outreach program that we are doing. Since January of this year, we have had 279 Burke County residents that have received overdose prevention education, overdose prevention materials, Hep C and medication-assisted treatment. And this is all done in the setting of mobile outreach. Now, what does that mean? For Burke County, we know we're a very rural county, right? So we have a lot of places where you can't even walk to the local Dollar General. Now, you know, if you can't walk to a Dollar General, you're kind of out in the sticks somewhere, right? Out in the boonies, out away from things like access to Lyft, access to Uber, access to basic medical care. But yet we have a mobile outreach team that goes out 5 days a week to provide services to individuals who will either not have transportation to be able to come into a clinic, or simply who are too afraid to come into a clinic due to the shame and stigma of opioid use disorder or substance use disorder. Maybe they're scared because they have wounds that they don't know how to explain. Maybe they have situations in their families that past history has said, we can't trust medical personnel, or we can't trust other emergency personnel. Those things kind of pass down through generation. And so we're doing our best to address that by breaking the shame and the stigma, by providing care wherever they are, whether it's in a tent city, or it's in a shanty, or it's in a home, in a living room, in the parking lot of a Wendy's, wherever it may be. We go to where they are without judgment and provide care to them in a medical model. So what does that look like? The expansion of our team in the last year has included not only Tim Nolan, our nurse practitioner who heads up our team, who works for High Country Community Health, but it also includes now an LCSW, a mental health counselor, a certified phlebotomist. We have someone who's going to be coming on board to specialize in wound care. And we do this with peer support. People who've lived the experience who are now working with people living the experience. And that's how we build trusting relationships. And some of these individuals we have served for a long time, but every week we meet new people who are seeking services and are happy to be served. Over 2,000 interactions since January have occurred with these individuals. It equips them with the crucial knowledge, resources, and tools to prevent the spread of disease and to reduce overdose death. And then finally, we have an enhanced access to treatment through this mobile outreach team, through our partnerships, through High Country Community Health, through Burke Public Health, through other community organizations that is help funded by the Dogwood Foundation. We have made over 120 linkages to care for these individuals. Now, that's not a referral. That doesn't mean that we hand someone a piece of paper and say, go and call. What we say is, let us help you get connected. Because if we have a trusting relationship with the people that we are serving, then they will trust who we refer and link them to. And that's how we get people engaged and keep people engaged in care. So as we reflect on these achievements, it's imperative to maintain our momentum and remain vigilant in our fight against this crisis. So looking ahead, this is what we're hoping to do. One, we want to continue expanding our access to naloxone. It's evident that we do have a good coverage in this county by the reduction in the number of overdoses that are coming into the emergency room, but that also tells me that we still need to do more. 51% is not 100%, and that's the goal to get to. So we're going to widen the access to naloxone, which is the life-saving medication for opioid overdoses, and we're going to continue to focus our partnership with Burke County Public Health to make sure that every citizen has access to naloxone if they desire. We're going to continue with our unique delivery of services at Olive Branch, enhancing our mobile outreach programs, because we know that this is a proven way to get people engaged and keep people engaged in care. And then finally, we want to strengthen our current community partnerships. We will continue to listen to the voices that matter the most, those people living in this crisis. Those voices should be the priority voices in this room. But we know that because, again, of shame and stigma, because it may not feel safe for them to be present, they've entrusted us to lift their voices and say we are here and we deserve health equity. We deserve the right to same treatment. We deserve the right for dignity, the right for autonomy. But most importantly, we love our community and we want to be as healthy as we can be. We'll continue to strengthen our partnerships, including healthcare providers, with EMS, with law enforcement agencies, with nonprofit organizations in the county, community leaders, because we want to leverage collective expertise and resources. The progress we've made in improving opioid trends within Burke County is a testament to the power of collaboration, determination, and compassion. Make no mistake, we still have a lot of work to do. But together, we have the opportunity to create a brighter, healthier future for all Burke County residents. I'm confident with our continued dedication and innovative approaches, we will build upon these achievements and further enhance the well-being of our community. I hope you will join us in this effort. Thank you for your unwavering support and commitment to this vital cause. And now I have the honor to introduce a friend and partner in this work, Dr. Anthony Frank, Chief Medical Officer and Senior VP of Medical Affairs at UNC Health Blue Ridge. Dr. Frank?
Thanks, Michelle. Good evening, everybody, ladies and gentlemen, esteemed colleagues, friends. As I was looking around at the 5 o'clock meeting earlier and then at the reception, it was really amazing to me to see some of the folks, friends, new and old. And as I was reflecting on that, it was really interesting trying to break it down to the denominator of who actually and why actually we were all here. And I believe the answer is, one, because we care for other humans, and number two, we care about our communities. And so, again, thank you for being here. As Michelle said, I'm Anthony Frank. I am the Chief Medical Officer for UNC Health Blue Ridge. I also serve as the Vice Chair for the Board of Health in Burke County, and I am a North Carolina emergency physician. I began practicing in the state of North Carolina in 1997 and have pretty much been from the coast to the mountains now, practicing in about 20 of 100 counties in our great state. And I would tell you that we have a substance use disorder problem in our communities. If you've been with us for the ride so far here in Burke County, we've had a number of forums. We've had Beth Macy, we've had Stephen Lloyd, we've had an internal group of concerned physicians and other members of our community where we talked about how we can make medication-assisted treatment more available to our communities through our practices and our physicians. As we've done that, we have the opportunity tonight to have another fantastic program that I think you will all enjoy and will certainly not disappoint compared to the other ones previously. I would like to thank a couple of folks, our sponsors this evening, UNC Health Blue Ridge, Burke County Public Health, Olive Branch Ministry, and Dogwood Health Trust. And as all of you in the audience are aware, it's not those organizations, but it's the people that make up those organizations that make them so great. And so there are a lot of those folks here tonight that have assisted us in making this program possible, and I would like to extend a warm thank you, and we really appreciate all that you have done to bring this together for us. Along with that, thanks to Dr. Gupta's staff, as well as Attorney General Stein's staff, and the CAMA staff for being here late with us this evening and dealing with a lot of the scheduling difficulties that we've had as we've done this program for you. Change is hard, but change is what is needed in our communities in order to address substance use disorder. Tonight, you'll hear about some of the work that's being done more at a state level as well as a national level, and how that work contributes to the work that all of us are doing locally in Burke County, as well as in any of the other surrounding counties throughout the state of North Carolina. As I was preparing this morning for this, I had the opportunity and was flipping through a journal, and I came across a quote that I thought was very appropriate for this evening. And it was generally attributed to Mother Teresa, which, as you think about the work that we all do in healthcare and with many of the patients with substance use disorder, I think we could all aspire to be as good and wholesome in our care as she was in the folks that she missioned and treated. And the quote says, "I alone cannot change the world, but I can cast a stone across the water and make many ripples." I alone cannot change the world, but I can cast a stone across the water and create many ripples. One of the ripples that I would like to tell you about came to us in healthcare here at the hospital in town from one of our third-year medical students. We have a new partnership with Campbell University School of Medicine this year, and one of my third-year medical students came to conference one day and said, "I need to tell you a story about a patient that I encountered so that I can understand this better." And she described a patient on our women's health unit who had come to deliver a baby. Unfortunately, this mom had substance use disorder problems, and shortly after she delivered her child, she looked at the care team and said that she needed to leave. Now, most of us would not understand why or how that could ever occur. How could a mother leave her baby? Unfortunately, that's part of this disorder. The rational thought does not exist, and in the absence of medication-assisted therapy, the opportunity to restore some of this medical and human decision-making is just not possible. This mom left her baby in our care and went to seek the substances that she needed in order to continue her life, but this one was a bit different. She actually returned the next night and the night after that. And so there was something there that really was more than the substances. And this is an example of one of the patients that we truly have the opportunity to make a difference in as we prescribe medication for substance use disorder. I wish I could tell you that we fixed all the problems and have all the answers and all the solutions. That's not true to this point, but we do have an awareness, and the awareness allows us to help try to implement those solutions. And again, the awareness of y'all being here tonight, and as we continue to talk about this disorder, is really why we're here and why we continue to do these forums. So as we move through this, again, the opportunities for our community to have these discussions, we greatly appreciate your attention and you being here. And at this point in time, I would like to turn the program over to a great friend and colleague, Mr. Danny Scalise, our Public Health Director, to further introduce our guests. Danny.
Good evening, everyone. Thank you, Dr. Frank. Thank you, Michelle, for your comments. I'd like to say quickly thank you to the staff at CAMA. They're wonderful to work with. They're very helpful to us when we put this on and kind of make it effortless for us that are planning things. I'd like to thank my staff at Burke County Public Health and the staff at UNC Healthcare Blue Ridge, who were very helpful in planning this event. We've been working on it for a while, and I get to introduce you guys to some new friends of mine and an old friend of mine tonight. The first thing I want to say is Dr. Gupta, and there's a good doctor joke about him being late, is running a little bit late, and we're going to get started and shove him on stage about the time that he gets here. But I do want to bring onto stage my new friends this evening, Mann, who is the National Addiction Correspondent for NPR, and the Attorney General of North Carolina, Josh Stein.
Well, it's wonderful to be here. My name is Mann, and I am NPR's very first addiction correspondent. And it was a real honor to be named to that post about 4 years ago. And it's a real honor to be with you here tonight. And Attorney General Stein, it's great to be here with you. I'll call you Josh from now on, but
Please
I just
do.
wanted to sort of welcome you here as well. And as you heard, Dr. Gupta will be along shortly and presently, and we'll include him in the conversation just as soon as he's here. I'm sure he'll have compelling things to say, but we were talking backstage, and I think we could talk all night about what we've seen in this crisis as it's unfolded. Before we get started with our conversation, I do want to say that you'll see the QR code up there, and the end of this program will be an opportunity for all of you to ask questions, and they'll be channeled up to me. I'll be able to see them and share them with our guests, and so please do take part. We really do want to hear your voices. Let me just ask very quickly, we can just barely see you out there, but give a show of hands, anybody who has been directly affected by this addiction crisis that we've had unfolding here the last couple of decades in America and in North Carolina.
A lot.
One of the things that I loved about the program earlier, Katie was up here talking, and she talked about the fact that there is a lot that's happening that's really hopeful in Burke County, around North Carolina, and around the country. But there has been such a lot of pain and a lot of loss that's come to this moment in my family, and many of your families. And so what I'd like to do before we start talking is just have a very brief moment of silence to share thinking about those folks who are not here with us. thank you for sharing that. And Josh, it's wonderful to be here with you.
Thank you.
We've spoken on the phone many times, and I've heard your thoughts about all of this. And of course, you've been a leader on opioid litigation, on thinking about the opioid crisis as it's changed and evolved. And so let me just start with kind of getting your sense. You know, you obviously have this big picture view of what's happening in North Carolina. Where are we at right now? I know there is still people dying. There's people still very sick from this, but there is settlement money starting to hit the ground. So give us just sort of that big view that you're seeing.
There are good things and there are bad things when you take that sort of 30,000-foot view. Probably most fundamentally, what is bad is that as many people are dying of an overdose as ever. It's about 12 North Carolinians die of a drug overdose each day, which means that today there were, on average, 12 families affected. Yesterday there were 12 more, and sadly tomorrow there'll be another 12. And of those 12, about 9 of them have some kind of synthetic opioid in their blood. It's later determined. So more people are dying than ever before. We do think there's a plateau. We don't have the numbers from 2023 final yet, but the guess is that it's marginally less than it was in 2022, which would be an incredible blessing, because you don't ever go down until you, what they used to say, bend the curve. You got to bend the curve before you can get it all the way down. So too many people are dying. That's fundamentally the case. But there are a lot of reasons for hope. And Burke County is a perfect example of why there should be hope in the community, because a bunch of people with big hearts and big brains have come together to come up with a strategic plan. And now there is a dedicated source of funding to help finance that plan. And so there are a lot of innovations, and we can talk more about them as we go on this evening, that are being carried out not only in Burke County, but all over the state. And when you see people, when you can finally match sort of people's passion and innovation and dedication with a funding source, that's when good things can start to happen.
Now, as a journalist, I'm often accused of being a downer, and I don't want to do that the entire time. We're going to talk about a lot of those hopeful things that are happening, but sometimes as I'm traveling around the country, it seems like there's almost a race here between innovation and harm reduction and healthcare on the one hand, and it does seem like that's getting better. On the other side of the equation, it seems like the drug supply gets more toxic every year. Xylazine is now in a lot of the fentanyl supply. Other chemicals are being added by the cartels and the drug gangs. Do you think that we're getting to the point where we're going to start pulling ahead on that, or do you worry that as these more and more toxic drugs arrive, it'll be hard to maintain that progress?
I mean, I think there's a reason why the numbers are worse today than they were in 2017 when I started my term as Attorney General. And even then, as I would travel the state and meet with leaders, sheriffs or DAs or county commissioners, I think Johnny Carswell. Johnny, are you here somewhere? Yes, sir. All right, good man, good man. Johnny's been working on this issue for a long time. And there were people like him, and I would travel around the state and hear how bad things were. But what we were talking about then in 2016 and 17 were really the pills, because that's what started this whole crisis, where the drug companies essentially just pouring pills into communities and overwhelming them with supply, and a lot of people got addicted. Well, then it got to the point where when the pill supply started getting restricted, folks started going to heroin, which was cheaper than the pills on the black market. And that was coming from Mexico, and that was happening sort of in the teens, 13 to 17, 18. And then the drug traffickers realized, you know what, instead of having to wait for the rain and the seasons and the harvesting and the production of heroin, why don't we make this in a lab like they make we all know the word fentanyl, but fentanyl is a drug that you get prescribed at a hospital. It exists. It was created in a lab. And then they realized, well, why don't we just create that, since it's so much more potent than heroin or even the pills? And that created sort of this third wave over the last few years with fentanyl. And now what we're seeing is, as you described, is the entire illicit drug supply completely corrupted. So that it doesn't even matter what it is you're out there trying to buy, whether you're trying to buy methamphetamine, or you're trying to buy cocaine, or even sometimes marijuana. The drug dealers will lace or corrupt, pollute, or poison that drug with fentanyl in it. It makes people more addicted quicker. So it is exceptionally worrying that we now have this problem where it's so cheap and so plentiful to manufacture fentanyl, and it's now so pervasive. There is no easy way to get out of this. And fundamentally, at the end of the day, what we have to do is create communities where people aren't seeking out the drugs.
You know, Americans like solutions to things, and God knows we all want a solution to this. But one of the things that I often hear from experts is that, as you just said, this is a public health crisis that probably has a pretty long arc, and hopefully a positive one.
Yep.
And there's some work in that direction that's really hopeful. But as an elected official, as a leader of this, that must be a tough message to bring to people, that this is not going to be something like we had with COVID, for example, where, brutal as it was, it had a fairly short life in our realities. Talk about what is it like when you have to say to people, we're going to be fighting this for a while?
Well, there were two reasons why, when we structured the settlement in the legal case, that these terms were essentially 10 to 18 years, depending on the company. Some of them, there were a couple companies that paid in 3-4 years, but most of the companies paid either 10 to 18 years. Honestly, I was happy with that, because if we got big numbers and they were over 3 years and we distributed all those money in 3 or 4 years, there would be nothing left. It would just have come and gone like a huge tidal wave and gone away, and we wouldn't have anything left over. And what we need is a permanent infrastructure of providers and services to help people who are struggling with addiction. And right now, the predominant addiction folks are concerned about, and they're killing people, are the opioids, the fentanyl. But honestly, in 5-8 years, we don't know, because 5 years ago, we didn't know we would be where we are today. And so what we have to build is a system that is resilient and responsive to what is coming down the pike, so that whatever it is, we have ways to address it.
I want to talk more about the settlement money in just a second and really dig into that. But let me ask a question or two more about the supply side of this. Mm-hmm. Some of the experts I talk to, including people who are very hawkish on interdiction and on policing, they think stopping these synthetic substances is just a damn hard proposition. It's so cheap to make, it's easier to smuggle. The cartels can lose a lot of it and not blink an eye because it's so cheap to just make more of it. Mm-hmm. So give us the most realistic assessment you can. How effective can we be at curbing the supply side, especially in a place like North Carolina? I've been talking to people here. It's a crossroad of highways. It's transportation coming through here. With federal help, with all the players in place, can we do more there, or is that not realistic?
When you have a problem as intractable as the drug crisis, opioid crisis in this country, there's no solution you can take off the table. So you have to think about it from the supply side, is how can I maximize the reduction by restricting supply? And then you have to think about it on the demand side. What can I do to maximize or decrease the number of people who want these drugs? Because what we're trying to do is make the cost of business be at a higher point than what the economics of the demand are. And that's when drug traffickers go out of business. And so there are things we can do to increase the cost of doing business. Does that mean we can stop the supply of fentanyl? Of course not. But we can make it more expensive on traffickers in a few different ways. I actually had called on Congress to appropriate $300 or $400 million for these fentanyl scanners, which, by the way, the U.S. government had already bought, and they were sitting in warehouses. They just were not deployed. And what they are is essentially, if you've flown on an airplane and you go through the X-ray machine, it's like a massive X-ray machine for trucks. And the trucks drive through it, and then you can see where the cavities are in the trucks, because the engineering is insane. Like if you talk to law enforcement who when they finally get a truck with all the supply, and usually it's because of an investigation we've done with wiretaps, and they know to go get the truck. But they know the drugs are in the truck, and it can take them a long time to find the drugs because they are so incredibly creative with the engineering and where they create the cavities. So it's very difficult to stop it all. We're never going to be able to stop it all, but we can stop a lot more than we are. And these scanners finally did get appropriated by Congress, and Biden signed it into law. There are going to be many more at the ports of entry. And we need to do a good job as law enforcement, coordinating our efforts locally, state, and federal to go after the drug trafficking networks and again, raise the cost of doing business. Get as high up on the hierarchy as you can to make the cost more painful. We're considering a money laundering. I put together a fentanyl task force here in North Carolina of state, local, and federal law enforcement. One is to just improve coordination and communication among the different agencies because we all work together. But the other is to come up with new ideas. And one is to make a state money laundering statute like the federal analog, because if you can take the money, then you're making it more expensive. So to answer your question, we can reduce the supply, we can increase interdiction, we can make the cost of doing business more painful. That said, I don't think we'll ever stop it altogether.
In helping you do that work here in North Carolina, some state attorneys general, and this has obviously been very political at times, but some have been critical of the Biden administration, both for border security and for not convincing the Mexican and Chinese governments to be more forceful at shutting down chemical supplies. How, you're in a position to be somewhat, you're a Democrat and the president is a Democrat. How would you rate him? Do you think he's done, all he can do? Do you think the administration can do more there to help North Carolina, get ahead on this?
Only they know what more they can do, because I'm not sitting with them when they do their jobs. I'm not on the call when he's talking with the premier of China. He raised it with him, which shows you the prioritization that this administration has given to tackling the issue. And basically, for those of you who don't know, the way fentanyl comes to the U.S. is the precursor drugs are from China, shipped to Mexico to cartels, which then have essentially factories, drug factories, where they make the fentanyl, and then they put it in vehicles, and the vehicles come through ports of entry. So it's not a matter of securing the border can help when it comes to illegal immigration, but securing the border is not what the issue is with fentanyl, because they come through ports of entry. And when you look at the arrest rates of the people who are driving the vehicles, either passenger cars or trucks, over 90% of the people arrested are Americans. So these are people who have obviously a lawful right to come into this country. That's why I urge the Congress to distribute these scanners so that we can do a better job identifying which vehicles have these cavities where fentanyl can be snuck into the country. So I've communicated to the White House. I've met with the Vice President and Dr. Gupta, and both applauded and encouraged them to do as much as they possibly can to deter China from the precursors and Mexico to police their own illicit drug manufacturing. So I wish, here's one thing that is factual, is that more fentanyl is being captured at the border today than it was 4 years ago. But that doesn't mean that more isn't coming in. We know that a lot's coming in.
Right. I mean, my sense is that the supply and the cost has remained fairly aggressive pretty much everywhere in the country. And I think the Drug Enforcement Administration's numbers back that up. Let's talk about the settlement money a little bit. You were obviously a major player in bringing that litigation and negotiating. And let me just have you just look back a little bit. How significant was it winning that money, and talk about how hard it was to put that together?
The settlement, when you aggregate all the different companies, it's hard to really even remember how complex the whole thing was, because you're not only dealing with 50 states, but literally thousands of local jurisdictions also sued. So that's just on the plaintiff side, 50 plus 3,000 or 4,000. Then on the defendant side, it wasn't just one sector. It wasn't just the distributors. It was the manufacturers of the drugs, the distributors of the drugs who took it from the manufacturers, to the pharmacy chains, to including the national pharmacy chain. So you had the entire distribution chain of players, and corralling all of those actors was really challenging and incredibly difficult. I'm incredibly grateful. One of my staff people, Steve Mange, is here. My first assistant at that time was a man named Swain Wood. Another Assistant Attorney General Daniel Mosteller. Just brilliant people who worked nonstop for like 3 or 4 years. Incredible effort, and it's exceptionally meaningful. Is it enough to solve the problem? It is not. Is it enough? We want more, but it was the most we felt we could get without, frankly, ruining the drug distribution industry in the entire country. So $50 billion, it's the second biggest state settlement in history, only to the tobacco case from 25 years ago. And in North Carolina, our share is $1.5 billion over the 18 years. And we put in a lot of protections to ensure that that money actually goes to addressing the problem and saving lives.
I was looking back at stories that I've done in the past where we've spoken, and one of the moments when I interviewed you in 2022, you made that point. You said it's not a perfect deal. You know, you wish you could get more, but you said this will save lives. And that is often a thing that I think as we talk about all the different pieces of this, it can sound very bureaucratic, and it often is very bureaucratic. But tell me whether you think that's actually happening right now. Do you think in North Carolina, with the boots that are going on the ground, the actual programs that are getting funded today, are we seeing lives saved?
I think so. We don't necessarily know empirically yet because the data is still being collected. I mentioned that there was a slight reduction, estimated reduction from 2022 into 2023. There was a really encouraging story out of Robeson County, which, if just to ground it geographically, I-95 just goes straight north-south into North Carolina. The South Carolina border on 95, where you see the south of the border, it's on the north of the border is Robeson County. Very poor, terrible adverse health outcomes. Reported a dramatic decrease in overdose deaths last year. So there are these shoots of optimism that exist. And again, I'm just certain, because I know a lot of the people who are on the ground doing the work, the people like Michelle, who's distributing the Narcan or distributing the syringe supplies, clean syringes. Those people, if they're not out there doing it, more people are going to die. I'm just absolutely certain of that. And so making sure that there are funds to support these community organizations that are really doing the Lord's work is really rewarding.
You know, in parts of the country where NPR has done reporting, there is a clear sense that despite all of the best ambitions of the deal, a lot of this money is being diverted to pothole filling and to projects that are probably not directly related to addiction recovery. How do you think North Carolina is doing on this front? My sense is that it's better here and that there is more focus and more discipline in getting the money to the problem.
Experts as respectable as John Oliver, and you know John Oliver on HBO last week, tonight, sure. He actually did a story on this his big story last week, not last week, but 2 weeks ago, was on this topic. And I was really proud because he was criticizing all the states that aren't doing anything, and he recognized North Carolina as one of 2 states for having the greatest transparency. And that was actually reinforced by Johns Hopkins School of Public Health, who did an analysis of all 50 states and recognized North Carolina and Rhode Island as the 2 states with the greatest transparency on how we distributed the funds. I wanted to achieve 3 things with the settlements. Wanted to make these companies pay for the damage that they had done. I wanted to change the way they do business so that something like this could never happen again. And I wanted the money to make a difference in people's lives. And so the team I talked about earlier worked incredibly hard with Johnny Carswell and the County Commissioners Association, because they were plaintiffs on the same side of the table with us. And we made a number of strategic decisions along the way where we put the vast majority of the money back to the local governments, to the counties in the big cities, because when you think about this problem and the way that it bumps up against government, you see it in jail, you see it in the public health department, you see it in the Department of Social Services. These are all funded by the counties. And so that's where the solution needs to start as well. So we put 85% of the money back out to the counties. Now, not all counties are on their toes the way that Burke County is. Burke County has really great initiatives that they're considering. But I've been incredibly both impressed and really, I feel confirmed that we made the right decision, because I did something like 50 roundtables last year around the state in over 50 counties, 60 counties. And just to hear from them on how they're spending their money and seeing like, yeah, we now have 3 peer support specialists when we didn't have one before. We now have a drug treatment court that we did not have before. We have an MAT provider who did not exist in this community before. There are all these things happening that are really reaffirming.
And my sense, I sat in on a little bit of the discussion that happened before earlier this afternoon here, and there's also been a real push for transparency, making sure that there are financial reports so that the public can go back in, and there's even a dashboard where people can see. Talk about why you felt that was important, that people could see the dollars and where they were landing.
Well, because I understand human motivation is when you're held accountable for what you do, human beings tend to do a better job. It's human nature. And so the more transparency we have on the decisions that we're making all across the state, 100 county commissions in North Carolina, they are all having to make important decisions. Well, I wanted the people in their communities to be able to know what decision they made, who did they give the money to, how much did they give them, and importantly, what were the outcomes? What did that money achieve? Because we have this 18-year lifespan of the deal, I don't expect any county to get it right year 1 or year 2 or year 3 or year 8. No county's gonna get it right because this problem is gonna mutate over time. And folks need to be responsive to the conditions of the moment. And that's what this transparency will give people, is they'll be able to say, look, you gave all your money to this organization, and if you look at their outcomes, they're not delivering. But meanwhile, there's this other organization that is doing some other service that's really making a difference, and we think you should fund that next year. And we have that opportunity here in North Carolina. And for folks who want to know, the website's very easy. It's ncopioidsettlement.org. We call it the Core NC, Community Opioid Response Engine of North Carolina, ncopioidsettlement.org. And you can put in Burke County, and you can see how much money Burke County is getting in year 1, year 2, year 3, over the whole 18-year lifespan, because it kind of goes up and down. And then each county has to report on how they've spent their money.
I want to talk a little bit about stigma and the way that the sort of the public culture around addiction has shaped this conversation. When I first started talking to you some years ago, it felt like there was a real consensus, at least some sense of that harm reduction and public health were the main focus of the response. Since then, there's been something of what, in my reporting, I've sensed kind of a backlash. People saying, let's maybe pivot back to harder, more punitive responses. And so let me ask you a couple questions about that. First of all, just broadly, when you talk to local leaders, when people across North Carolina who are going to be shaping the response in all of these small communities, where do you think folks are at in terms of seeing this as public health versus, I guess, crime, which it is criminal activity? How does that play out right now?
I think we're still in the former camp for the most part. I obviously be interested to hear other people's perspective on this. But one benefit of having counties come up with their opioid response plan is that most counties would sort of captain their public health director to be the one who kind of coordinates, okay, we need to hear from law enforcement, we need to hear from the community nonprofits, we need to involve the hospital and the treatment centers. So I would say the most typical place, obviously each county can be a little bit different, most typically we would have county commissions identify their public health director to kind of take the lead on that, which I think turned out to be a really good thing because they understand the holistic challenge that we all face. So I think that North Carolina is still approaching it more from a public health perspective. And look, the sheriffs, they know who's in their jails, and they get arrested repeatedly. And they get tired of seeing the same people over and over again. And if there actually is a program that can reduce the likelihood that that person will come back to them, that's what they want. And we actually see an increasing number of sheriffs, even some rural, very Republican sheriffs, having MAT in their jails so that when they leave jail, they can then be connected with a service provider and kind of take that urge to go use again off the table when they get out of jail.
So in terms of, like when you talk about these, the settlement money going to harm reduction, things like needle exchanges and that sort of thing, you're not starting to see any kind of major pushback on that? That doesn't feel...
I'm not seeing that. I mean, there are definitely going to be communities that may have issues depending on how it's playing out in their locality, but for the most part, we all still sort of have a sense of what the winning strategies are.
Let me ask you, and we're going to get to audience questions, which I see are starting to appear here, and we'll go to some of those. And let me just say to folks who are running the screen, as big as you can make the questions will be great. Right now, I'm going to have to get down on my hands and knees and read it to Josh from there, but I think, yeah, okay, this is looking great. Okay, good. Yeah, that's just right. If you get it at that size, that'll work. Let me wrap up with you with two questions of my own, and then we will go to that as we wait. And also, if you guys could put on the screen when you have a second what you think the situation is with Dr. Gupta, just so we know how to frame that. This is a question I often ponder myself, and I'd love to have you think out loud about this. We had over 100,000 people die last year. That's the best numbers, and over 100,000 the year before. And sometimes those numbers just, when you think about it, it's on a scale that is, this is not really a drug crisis like anything that we've ever seen before. And yet sometimes it feels like we're kind of running the same playbook, getting better at it, doing more. But I wonder if you feel like even now the country has, we saw, let me just use the example that often gets trotted out, the way we responded to COVID. Within a very short period of time, the country was saying, COVID is the fight. And here, we're losing, young people we need for industries. We need them to be having babies. We need them to be our entrepreneurs. So I wonder, as somebody who's really at the heart of thinking about this, are we starting to be at the kind of scale that's needed to tackle a public health crisis that's killing that many people?
We're probably not. We should be doing more than what we are doing. It's devastating to think about the numbers that we are losing on a daily basis. And I told you that when I talk about the North Carolina, when we first started working on this issue in 16, 17, it was like 4 people a day, and now we're at 12 people a day. So it's gotten meaningfully worse as the drugs get cheaper and more deadly. So we have our work cut out for us. I do believe that there is a broad consensus, it doesn't mean it's universally held, that we should be approaching this from a public health perspective, that to the extent we can reduce the number of people who are seeking these drugs, we're all better off. Those people are better off because they're able to live their lives and wake up in the morning and ask themselves, what do I want to do today? Instead of waking up and saying, where am I going to go get this chemical to put into my body? And I will do anything to get that chemical. So that person's better off, but then we're all better off because so much of crime, if you talk to law enforcement, the people who are in jail are not only there for the drug crimes themselves, but so much of the other crime is related to the drug problem, whether it's stealing from people to feed their habit, or violence that occurs in illicit drug sales. So we're all better off if we can reduce the number of people who are addicted. And I think there's a recognition that we can do a better job. This was a factor in North Carolina expanding Medicaid last year. We're one of the only states with a Republican legislature that in recent years has expanded Medicaid through a policy decision as opposed to a court or a referendum. And the sheriffs were a really critical partner in making the argument to the legislature that we need Medicaid expansion. We need more service providers offering buprenorphine and methadone and other treatment options. And if we don't have a means of paying for it, they're not going to come here. So I think there is a recognition, and we need to be doing everything we can to reduce the demand.
Let me ask my final question, and this is going to sound like a wrap-up question, but then we really are going to go to your question, so we're about to get you involved in the conversation. We've talked about the different pieces that are being put into place, a lot of them very positive, and especially in places like Burke County. So let me ask you, as somebody who's really been paying close attention to this and seeing it from a good 40,000-foot level in North Carolina, give me your most hopeful narrative of how we really get to the other side of this. Let's say to the point where we get, like, say, 2/3 fewer fatalities per day, or we've cut 2/3 of the deaths per year. How soon? How do we get there? Talk us through how you hopefully see that playing out.
So, there's a young man from Greensboro named Chase Holloman who, when he was a teenager, overdosed 3 different times and was only brought back to life each time because of naloxone, the miracle overdose reversal drug. He eventually was able to overcome his active addiction and long-term recovery. He went to UNC Greensboro, then he went to UNC and got a master's in social work. He went back to Guilford County, Greensboro, and did distribution of Narcan. And now he works for the federal SAMHSA, whatever SAMHSA stands for, the Public Health Agency. And
I couldn't tell you off the top of my head what SAMHSA is.
And so he is an exemplar of hope. And he is so far from unique of people who themselves experienced the hellish existence of daily addiction and what they ended up going through just to try to get that chemical in their body. There are 2 women, I'll give another example, in Buncombe County. One of them, they work in the jail, and they will partner with a service provider, opioid use disorder provider on the outside, but they start the treatment in the jails in Buncombe County. And they're the ones who kind of screen people out and say, are they candidates for this program? And when I met her, she has tattoos all up and down her arm. She says, my criminal record is longer. It's like 7 or 8 pages. Like, she actually had it to show me. Like, that many arrests. She said, I was in and I was out. I was in and I was out. I was in and I was out. And she's like, now my mission is to help who I was at that time today. And there are dozens, hundreds, thousands of people like that who have been able to get to a better place. And in fact, there are more people living a lifetime of recovery than there are in active addiction in this country. So even when you look at it globally, individual as opposed to just individual examples, there's a positive story to be told. And those people, these peer support specialists, I think they're the ones who give us the most hope, because they have walked a mile in the person's shoes. And if you haven't, you just are never going to be as an effective a messenger.
So I'm going to pivot to some of your questions. It sounds like Dr. Gupta is still a ways out, so we'll just keep going and having our conversation, and we'll just kind of update you on that as we get a sense for what's realistic to happen there. So Josh, I'll just jump into some of these if you're comfortable doing it. Okay, here's question number 1. what can be done to move the intervention for substance use disorder from the justice system to the healthcare system?
So a couple of things, both of which I've sort of touched on already. One is to have a system where people have health insurance to pay for the care that they need in order to stay well. Because substance use disorder is a chronic health condition, diabetes, heart disease, and there are medications that can help. One of the things about opioid use disorder that is distinct and more hopeful than a lot of other drug addictions is there are actually very effective medications to deal with it, the opioid antagonists that like buprenorphine, methadone, naltrexone. So there is medicine available to help people, but you need a way typically to pay for that medication. That's what insurance does for us in this country. Medicaid expansion here in North Carolina was a huge win. There's still people without insurance, but that was a positive story. The other thing is the example I gave in Buncombe County that is growing around the state. I don't know what the latest number is, but it was like a half dozen a few months ago of counties which are providing treatment to people in jail and starting them on their course of medication-assisted therapy so that when they get out, they can go to an outpatient clinic and continue their healthcare treatment. And it just increases the likelihood of success incredibly. I mean, what Buncombe County had achieved was really quite remarkable because the population most at risk of overdose death are people leaving incarceration. Because they're incarcerated, they're in jail or prison, they aren't using actively, they come out of prison and they immediately go use at the same level that they used before they were incarcerated, their body can't handle it, and they overdose and die. Very high proportion of, that's the highest population at risk. Well, Buncombe County, through this program I described earlier, was able to reduce the mortality rate of people leaving their county jails to less than the general population, which is just amazing, just absolutely amazing. So doing that soft handoff from people who are in jail with addiction into a service provider who does outpatient work is a critical way of moving people out of the criminal justice system, literally, into the healthcare system, literally. But there are other things we can do on the front end, and law enforcement are doing this, like law enforcement assisted diversion here in North Carolina, where you come across somebody who's created a problem, violated a law, but instead of arresting them, you connect them to treatment, sort of before drug treatment court even comes into play. And they're, like in Hickory, they're doing that.
Mm-hmm. And let me just ask you, I mean, obviously in some parts of the country there have been experiments in broader decriminalization of small amounts of drug possession, efforts to expand diverting people away from the criminal justice system. Do you think more experimentation in that area is needed? Is that not something you're drawn to?
When it comes to something like marijuana, I think decriminalizing marijuana possession and essentially ensuring that tens of thousands of people don't get a criminal record, I think that serves a broader societal good. I don't know that we need to be doing it with hard drugs at this point.
Okay, here's another good question. Okay, this is kind of a long one, but let me get it here. Primary care physicians are uniquely qualified to take care of patients with opioid addiction, and yet the federal and the state government continues to underfund primary care. Rural areas are particularly in need of good primary care, yet there remains a deficit of these physicians. How do we change the trajectory both at the state and federal level? And Josh, as you talk about this also, I'd be curious to know if you have thoughts about how we just convince more primary care physicians to work in the addiction space, which is still something that's a real struggle in many areas.
Part of the problem is that we've really stigmatized drug treatment as a practice, a medical practice. I mean, the way for years buprenorphine, so opioids are powerful and very highly addictive. Buprenorphine is a partial antagonist, meaning it has some opioid capacity, but really it's about stopping the desire to take an opioid. So they're much safer and they're an important treatment drug. Well, it used to be if you were a doctor who prescribed opioids, you didn't require any special education at all. Any doctor can prescribe, and they could prescribe until we changed the law, as many pills as they wanted. But for the doctors who treat people who got addicted to all these pills that are being prescribed, who then treat this less dangerous drug, it can be abused, I'm not overstating my case, we made them go through a special class and have a limited number of patients that they could see. And we essentially were signaling to doctors, this is something that's really bad, and this crowd has to be a bad crowd. And so alarm bells.
It was pretty scary.
Yeah. And methadone, is there any other drug where medicine, where we make people go to a strip mall to get their medication as opposed to going to a pharmacy or going to a doctor's office? And so I think there are things that we can be doing as a society to encourage providers of all types. I mean, I think pharmacists are a really underutilized profession when it comes to treating opioid use disorder, because there are pharmacies everywhere. So I think that we just need to be more creative.
Okay, we've asked that one, so bump on to the next one if you would be so kind. Same one, bigger. Okay, so how does your office plan to hold counties accountable and ensure that settlement money is not used to fund non-evidence-based strategies?
So the agreement that we sign with the counties requires them to be very transparent in how they use the money. It restricts how they can use the money. It has to go to prevention, harm reduction, treatment, or recovery services. And if they do not spend the money, let's say they fill potholes, which is what everyone's always concerned about, then we can write them a demand letter. They can respond. If we need to, we could go to court. And one good thing about the payments over time is that we can take it out of the next year's payment if they don't live up to the terms. The other thing is there may be strategies that are permissible under the settlement, but just aren't good ones or are less good ones. And honestly, that's on the voters. I mean, the voters, one reason why we do transparency in government is so that if we screw up, you can hold us accountable. And so if you do not like the way your local officials are investing this public trust money, then get new local officials.
You know, I'm sure this isn't primarily the purview of the AG's office here in the state, but it may be a part of yours. And again, I'd be interested just to hear your view on this. One of the side effects of having addiction care be ghettoized for so many decades in America outside the main healthcare pipeline is that a lot of it's really bad. I mean, you can go to clinics that are expensive and taking up a lot of money, but they're not evidence-based. They're not using the latest science. A lot of them don't have MAT. How well do you think North Carolina is doing at making sure that the recovery resources that exist here are regulated or have proper oversight, they're safe, they're effective?
I'm not the best person to answer that one. It falls under the regulatory umbrella of the Department of Health and Human Services, and they have people who make sure that these groups do what they say they're going to do. I mean, we have championed legislation to go after the real scam outfits, which actually try to get people to come and charge them lots of money and then just abuse them. And we've passed laws against that, but beyond that, I'm not really an expert.
Great. Okay.
I saw one question that flashed by to which I have an answer.
Okay. All right. Okay, here we go. What initiatives or programs does your office or you personally support to prevent opioid addiction and abuse in North Carolina, particularly in youth? And how can we measure the effectiveness of those programs?
We've spent some time with the Department of Public Instruction evaluating some of the free curriculum that exists by providers to help young people avoid these drugs in the first place, so prevention strategies. And there are some really promising initiatives which try to help. I mean, basically, if you think about the risks that our kids are exposed to, and there are many, I mean, there's all kinds of addictions. There's the e-cigarettes, there's these hard drugs, there's social media addiction. What we want is for our kids to have the skills to make good decisions on the whole array of challenges and risks that are in front of them. And there are curriculums that do that, and we have worked to promote those to school systems across the state. We've also, in fact, I'm going to be in Greenville, North Carolina in the East tomorrow, doing a social media town hall with some parents and teachers, administrators, and students, talking about the risks of social media. And so we do these seminars. If you're interested, it's ncdoj.gov/nextgen seminars. So we try to get the conversation started in various communities and provide materials and encourage administrators to find particularly the free materials that can help their kids just develop the skills they need to be more resilient.
I saw a question pop up here, but let me see. It looks like I'm about to get some instructions about where we're going to go with the evening's program. While you guys type up the instructions of what you want me to do next, let me ask this question that came across that I think is really quite interesting, which is about the private sector. You know, one of the things I've heard here in Burke County talking to folks is, you know, that overdose and addiction has affected some of the manufacturing businesses. So this is an area where obviously addiction affects the workforce. And I wonder if you think the private sector has a role to play in any way in helping with this. I mean, it feels like an all hands on deck moment. What do you think about that?
I agree with that. And I mean, one thing is that much of our health insurance is provided through the private sector, through our employers, which is just an unusual choice that we made as a country a long time ago. But because of that, there's a real financial incentive by the companies to make sure that their workers are getting quality health care and getting well, because the most expensive, least productive worker is the one who's sick. There was one time back in 2017, 2018, there was an employer up here who told me from their HR department that they were actually paying weekly bonuses for people who showed up all 5 days. Like, their absenteeism was so high that they were rewarding people for 5 consecutive days of work. That's a huge concern, and what we have a collective urgency to address the problem. And if we don't have the business community, even the solutions that require the government to take a lead, like Medicaid expansion, if we had not had private sector actors who agreed with that, it never would have happened. Okay, so I'm hearing, sadly, that Dr. Gupta is in transit, but is not going to make it in time. We've got time for 2 final questions, and I'm going to reach for one of them from the board here, and then I'm going to ask a final question of my own. So this will be the last one we get to from the audience. Thank you all, by the way. These have been really great questions, so grateful for that. Have you drafted legislation, and I'm just ignorant about this, but it's a good question, to address the supply side of the crisis here in North Carolina? Yeah, the 2 main things we've been working on to strengthen law enforcement here in North Carolina, as I said earlier, to just raise the cost of doing business, really make it painful for these drug trafficking networks. One is this law enforcement task force that we've created of state, local, federal. The other is I've asked the legislature for a fentanyl control unit. And I have a group of specialized prosecutors in my office that support local district attorneys. That's how it's done here in North Carolina. The prosecutions are done by local district attorneys. And these cases, to bring these drug trafficking cases, are very time-consuming, very complex. The number of wiretaps that go out just to kind of work your way up the chain, it can take months and months and years. And so I've asked the legislature to fund a fentanyl control unit of specialized prosecutors within my specialized prosecutors unit to focus on these drug trafficking cases because they are so time-consuming. So I'm hoping that the General Assembly gets on board with that. My final question, and this is where we'll wrap up tonight, it reflects one of the questions that flickered across the screen here a bit ago, but I want to adapt it just a little bit. You know, one of the things that has been so difficult for me covering this
is how hard it's hit young people. And it's just, when you're in a homeless camp or you're, in places where fentanyl is really taking out a whole neighborhood, a lot of times it is the people that should be coming up and starting businesses and starting families and all of that. And I'm wondering if you have any thoughts, again, maybe leaning into the hope a little bit, about how we can begin to address the root cause of loneliness, of the sense of dislocation, and maybe if you just have thoughts about what it is with the young people who are, at one point I thought this fentanyl thing is just hitting people, who got hooked on the prescription pills back in the day, and they're sort of still, but it really seems like a lot of young people are still, being drawn into this world, and it's becoming more multi-generational. And do you have thoughts about how we can begin to get ahead of the draw of this and help people avoid it?
Yeah, it's interesting. A lot of the issues I've been working on have been about trying to protect kids, whether it's protecting kids from child sex abuse, or we were the first state to take Juul, the e-cigarette manufacturer, to court for creating this huge spike in teen nicotine addiction. We've sued Meta, Facebook and Instagram, for addicting kids to their cell phones, and investigating TikTok for the same reason. And so you see all these things happening, and then layered on top of that, you hear the Surgeon General say that there's a youth mental health crisis, that the number of children who are experiencing anxiety and depression and suicidal thoughts and self-harm and just terrible things, and it's huge numbers of kids. So there is something wrong, and I don't know if the phones are the main driver or contributor. I don't understand it well enough, but we have to do a better job of wrapping our kids with love, and making sure that they understand their value on this planet, in our homes, so that they have the resilience to deal with life's adversities, because life's hard and it will always be so. And we need to do everything we can so that kids, when they are 16 and they're at the party and somebody's like, hey, who wants a cigarette? Who wants a vape? Who wants a beer? Who wants this pill? All it takes is one bad decision, and you take a pill that isn't what you were told it was, and it's in fact laced with fentanyl, and that young person's life is over, and the parents are crushed, and the whole community is harmed. And so we've got to create young people who know to just not say yes, to say no.
Thank you very much. It's been an honor to talk to you, and a great conversation. And I want to thank Burke County for having us, and thanks to all of you who participated with your questions, and really great to be here tonight. So thank you all very much. Appreciate it.
Thank you.
Thanks, Dan. Good job.
Good job.